Thanks, Dr. Palmer and Dr. Mesa, for inviting me to speak with you all today. My name is Rupali Bhave, and like Dr. Palmer said, I was actually raised in Tempe, Arizona, and went to undergrad and medical school at University of Arizona. So Arizona is home, and it's always nice to come back. But right now, I'm at Wake Forest Baptist in Winston-Salem, where I am a clinician with a focus in MPNs and do clinical trial work in that space as well. So today I'll be talking to you guys about essential thrombocythemia. So what is it? It is a myeloproliferative neoplasm, so a bone marrow cancer, and it's a disorder of the hematopoietic stem cell, as we just heard a lot about. The majority of our ET patients are going to harbor one of three kind of mutually exclusive driver mutations, and as a result of those, you'll see this kind of persistent activation of a pathway called the JAK-STAT pathway, and as a result of that, you'll see a hypersensitivity of our hematopoietic stem cells, which again are those cells in our body that give rise to all of our other blood cells. This hypersensitivity of those cells to growth factors and cytokines, which are proteins that our immune system makes. This leads to overproduction of mature and functional blood cells, and in the case of ET, you see this sustained overproduction of platelets, your blood clotting cells, which then can lead to not only clotting complications, but bleeding complications as well. So how common is ET? Annually, we diagnose about 2 cases per 100,000 people. Median age at presentation is 65, but about 15% of our patients who are diagnosed with ET will have their diagnosis made under the age of 40. As I was mentioning, the majority of our ET patients are going to have one of 3 driver mutations, the most common of which is that JAK2 V617F mutation, which is present in 50 to 60% of our ET patients. These patients tend to be older. They tend to have higher hemoglobins or red blood cell counts and higher white blood cell counts, white blood cells being our infection-fighting cells. 3 to 4% of our ET patients are going to have a mutation in the MPL gene. MPL is our thrombopoietin receptor, thrombopoietin or TPO being the hormone that tells our bone marrow to make platelets. And 20 to 25% of patients will harbor a mutation in calreticulin. The more common of the calreticulin mutations are what we consider to be these type 1 mutations, which results in a 52 base pair deletion in exon 9, which is a portion of this calreticulin gene. And the less common is what we call a type 2 mutation, which results in a 5 base pair insertion in this exon 9. Calreticulin mutated ET patients tend to be younger, they tend to be male, they tend to have higher platelet counts, especially those with a type 2 calreticulin mutation. They tend to have lower red blood cell counts, lower white blood cell counts, and despite having higher platelets, this patient population is actually at lower risk for blood clotting. And then finally, 10 to 15% of our ET patients will be what we call triple negative. They won't have a mutation in either CALR or MPL or JAK2. And these patients also tend to have higher platelet counts and tend to be at lower risk for blood clotting complications. Now, I will say that these patients who have triple negative disease probably do have other kind of non-driver mutations. We see a lot of other mutations in about half of our ET patients, and they very likely played a role in how the ET came to be. So how do our ET patients present? So some of our patients present without any symptoms at all. Maybe they were scheduled for an elective surgery and they went to their pre-op appointment, they got a blood count, and they were incidentally found to have an elevated platelet count. Other patients, however, will present with what we call microvascular disturbances. So symptoms like headaches, lightheadedness, blurry vision, palpitations, chest pain, erythromelalgia. So this is a term that we give to some of of our ET patients who get kind of this burning sensation, oftentimes in their extremities, associated with redness and warmth that can be very uncomfortable, or distal paresthesias, which is basically numbness or tingling. A minority of our patients with ET will have a big spleen. It's not very common to see big spleens in ET in particular, but if it is, it can cause some discomfort. Some of our patients will present with superficial thrombophlebitis, so a blood clot in one of their superficial veins, which will then result in sort of pain and redness. And then some of our patients will present with what we call minor mucocutaneous bleeding, so some nose bleeding or gum bleeding. Other patients will present with or have a history of prior blood clots, either in an artery or a vein. And then some of our patients will have a history of or present with kind of major hemorrhage or bleeding. Hemoglobin or red blood cell count in our ET patients tends to be normal. The white blood cell count, our infection-fighting blood cells in our ET patients, also tends to be normal. About a fifth of patients can have an elevated white blood cell count. The median platelet at the time of diagnosis in our ET patients is about 700 or 700,000, but about a quarter of our patients can present with what we call extreme thrombocytosis, so a platelet count of over 1 million. So how do we diagnose ET? So there are these diagnostic criteria that I've listed here that were recently revised by the World Health Organization and the ICC. They're largely similar, so I've just listed them here. So in order to be diagnosed with ET, you need to either have all 4 of the major criteria or 3 of the major criteria and 1 of the 2 minor criteria. So what are the major criteria? Number 1, you need an elevated platelet count. Number 2, you need a bone marrow biopsy at the level of which, the changes are kind of consistent or characteristic of what we see in ET. So what is that? So typically when we do a bone marrow biopsy in our patients, we see a normal number of cells. We see a normal number of white blood cells, and you see sort of the normal number of white blood cells at every level of their kind of maturation. You see a normal number of red blood cells, and again, you kind of see the normal proportion of those red blood cells maturing as they should, but you see an overabundance of what we call megakaryocytes. So our megakaryocytes are the cells in our bone marrow that give rise to platelets. And what we shouldn't see is any scarring or fibrosis, which is what is indicative of someone with myelofibrosis. The third major diagnostic criteria is that you need to not meet criteria for one of the other bone marrow disorders that can also cause an elevated platelet count. And then finally, the fourth major diagnostic criteria is detecting one of those 3 driver mutations that we talked about, a JAK2, a CALR, or a MPL mutation. Now, you can still, again, meet criteria for ET if you're missing one of those 4 major criteria, but meet one of the 2 minor criteria. So what are those? Presence of a clonal marker. So as I was mentioning, about half of our patients with ET have other non-driver mutations that are present in these abnormal cells that probably played a role in how this disease came to be. And then finally, you want to exclude other reactive causes of thrombocytosis or an elevated platelet count. I wanted to touch on a couple of these points, just to sort of remind everybody that there are, these reactive causes of elevated platelets as well. Not everybody with an elevated platelet count is going to have a bone marrow disorder. And so what are some of those reactive causes? So iron deficiency can cause an elevation in the platelet count, blood loss, surgery, an acute bacterial infection, chronic inflammation like you might see in someone with an autoimmune disorder like rheumatoid arthritis. And then some of our solid tumors can have what we call a paraneoplastic syndrome that gives rise to an elevated platelet count. So you may see them in a colon cancer patient or a lung cancer patient. And then if you are missing a spleen, say someone got into an accident, had splenic rupture, had to have their spleen taken out, those patients will walk around naturally with an elevated platelet count. And then as a reminder, again, we have a lot of different bone marrow disorders that can cause an elevated platelet count, and ET is only one of them. And the reason I point this out is because they all really are very different, and a lot of them are managed very differently. And so it really is important to really, in order to accurately diagnose ET, you really do need a bone marrow biopsy to sort of distinguish between all these different bone marrow disorders that could result in an elevated platelet count. There's one in particular that is very similar to ET that you really need a bone marrow biopsy to distinguish it from ET, and that entity is something called pre-fibrotic myelofibrosis. So pre-fibrotic myelofibrosis is its own separate entity. I've listed the diagnostic criteria here. I won't go over them, but some of the distinctions between ET and this pre-fibrotic myelofibrosis, you can kind of tell just based on the blood counts, maybe some of the other blood markers. But really, the distinction is really made at the level of the marrow. And why does it matter? So we know that all ET patients have some risk over their lifetime of progressing to the scarring bone marrow cancer, myelofibrosis. We also know that all patients with ET have some risk over their lifetime of transforming into the more aggressive bone marrow cancer called acute myeloid leukemia. And it seems that patients with pre-fibrotic myelofibrosis are at slightly higher risk for progressing to myelofibrosis or for transforming to acute myeloid leukemia. And their overall survival, so their overall length of life, seems to be a little bit less good in comparison to essential thrombocytosis. I will say that we largely right now manage pre-fibrotic myelofibrosis very similarly to ET. As we kind of learn more about it, there are active clinical trials in development soon to open that'll maybe shift how we treat that entity. But again, part of the reason why I think it's really important for patients when we're trying to diagnose ET to have a bone marrow biopsy. So a lot of you guys may have already had a bone marrow biopsy, but in case any of you haven't, I just wanted to kind of go over how we do marrows. So at the back of our pelvic bone, we each have a ridge, one on the right, one on the left, and it's called our iliac crest and posterior iliac crest. And really, in most patients, we can kind of feel where that is. So what we do is we sterilize your skin. We have you kind of lay on your belly or lay on your side. We sterilize your skin, numb your skin, and then numb that ridge, that posterior iliac crest, with a bunch of lidocaine numbing medication. Make a small nick in your skin and then go in with the bone marrow needle and get what we call an aspirate or a liquid portion of your bone marrow and smear that on the slide and look at it under the microscope, and then get a solid portion of your bone marrow, which is called the core, which the pathology team slices and dices and stains and puts on slides for us to look at. Whenever we do a bone marrow biopsy, whenever we're evaluating a patient with an abnormal blood count, we're always looking at the peripheral blood smear as well. So we're taking some of your blood from circulation, smearing it on a slide. And as Dr. Nangalia pointed out, in ET, really, the smear looks essentially the same as someone without ET, except you just see an overabundance of platelets. So, and as was already pointed out, those are those little tiny kind of dirt-looking things right here. And then we do look at the aspirate or the liquid portion of the slide under the microscope, but a lot of kind of how we distinguish sort of ET is kind of the look of the platelet precursors called the megakaryocytes at the level of the core, so that solid portion. And these megakaryocytes in a normal patient versus a patient with ET versus a patient with prefibrotic myelofibrosis are going to look a little bit different under the microscope. So now we've made a diagnosis of ET, so what do we do now? What are the consequences of actually having a diagnosis like this? So what we know is that, broadly speaking, the overall survival of patients with ET is really, really very good. Median overall survival is 20 years. Median overall survival for patients under the age of 60 is 33 years. But it has been shown that it is still consistently a little bit inferior to that of patients of the same sex and age. So in the in this graph or chart over here, you can see normal survival in kind of the black line, and patients with ET, their survival is this red line, so a little bit less good. The green line is PV patients. The blue line is represents myelofibrosis patients, so a little bit less good. We know that over a patient's lifetime in patients who have ET, there's a small risk of transformation into AML or acute myeloid leukemia. That risk is less than 5% over your entire lifespan. There's also this risk of transformation or progressing to that bone marrow scarring disorder called myelofibrosis. The risk is less than 10% over your entire lifetime. And then there's about a 10 to 25% risk of thrombosis or blood clotting in our ET patients over their lifetime. There have been a number of sort of observational retrospective studies in ET patients that have kind of delineated how we might be able to better sort of estimate which patients with ET are going to live even longer than others. We don't necessarily make treatment decisions based upon that, but I just wanted to sort of point out some of the factors that have been kind of associated with better or not survival in ET. So there are a bunch of prognostic algorithms. This one is called the IPSET score, and it takes into account age, white blood cell count, and history of prior thrombosis or blood clotting to sort of stratify patients into low, intermediate, or high risk. There's another one called the AAA that was actually developed by Mayo in conjunction with the University of Florence that noted that older age and what a patient's absolute neutrophil count was, so your neutrophils are your bacteria and fungus fighting white blood cells, and what a patient's lymphocyte count, so your lymphocytes are your virus fighting white blood cells. And using those variables, they were able to sort of risk stratify patients into different sort of survival curves. And then, as I mentioned, about half of our ET patients are going to have other non-driver mutations or mutations in other genes. And it turns out that some of these gene mutations can be associated with slightly worse sort of prognosis. And so there's another score called the MIPS-ET score that kind of takes that into consideration. And there have been other sort of characteristics that have been identified as maybe putting one patient with ET at slightly higher risk of progressing to myelofibrosis versus another one, or one ET patient versus another at slightly higher risk for kind of transforming to AML over their lifetime, and I've just listed them there. But again, at the moment, I should point out that right now we don't have any treatments that we think can prolong the already pretty good overall survival of our ET patients. We also don't think we have any treatments that will necessarily decrease the odds of our ET patient progressing to myelofibrosis or progressing to acute myeloid leukemia, but we do think we have treatment modalities that will decrease the blood clotting risk. So in day-to-day practice, a lot of how we manage our patients depends upon how at high risk or not they are of having a blood clotting event. And the way we figure that out is based upon this revised IPSET thrombosis score. And what this score does is it takes age, presence or absence of a JAK2 mutation, and presence or absence of a history of having had a blood clot before, and risk stratifies patients into very low risk for blood clotting, low risk for blood clotting, intermediate risk for blood clotting, and high risk for blood clotting. And it kind of gives you an estimate of sort of the percentage of patients in each of these risk categories that are going to have a clot per year. I want to point out that one of the things that we don't take into consideration when we're trying to estimate how high a risk or not our patients are at having a blood clot, we don't take into account how high their platelet count is, because there's no correlation with how high your platelet count is and your risk of thrombosis or having a blood clot. So again, no treatment to date that we know of yet to improve overall survival, leukemia-free survival, or myelofibrosis-free survival in ET. But what we can do is we do and can control symptoms, and we want to prevent clotting complications and bleeding complications. And like I mentioned, because of that, really the way we manage our patients day to day is based upon where they fall in large part in this revised IPSET thrombosis score. Now, there are some goals that we have in all of our ET patients, regardless of what risk category you fall in. So we want to control all of our ET patients' other cardiovascular risk factors, like high blood pressure, high cholesterol, diabetes. And when we say we, I mean kind of in conjunction with our patients' primary care physicians. It's really important that our ET patients have really good primary care providers who are screening them for these other cardiovascular risk factors, and if they have them, then managing them ideally, because we think these are risk factors that'll independently increase our patients' risk of having clotting issues like heart attack or stroke. We want all of our patients with ET not to be smoking, we want everybody to be eating a healthy, well-balanced diet, and we want everybody to exercise. We also know that there have been some observations in ET and other MPNs that seem to suggest that patients with MPNs are at slightly higher risk than the average population of having other cancers. So we want to make sure that all of our ET patients are getting their age-appropriate cancer screening, so mammograms and colonoscopies, and we're wanting to pay attention from a clinician standpoint for sort of signs or symptoms that might be indicative that something else unrelated to ET is brewing. So we want everybody, to have all their cardiovascular risk factors managed, to eat a healthy diet, to exercise, etc., screen patients for colonoscopies. What else do we suggest in our ET patients? So antiplatelet treatment. And when I talk about antiplatelet treatment, I'm really talking about aspirin. There are actually no randomized controlled studies that support the use of aspirin in ET. It's sort of extrapolated from one of the studies that was done in polycythemia vera, but there is a lot of good retrospective data that has shown that patients with high risk for clotting ET are at higher risk for blood clotting if you don't put them on aspirin. Aspirin can also be really helpful in controlling some of those microvascular symptoms that I talked about, like erythromelalgia and headaches, when used either once daily or even twice daily. So I wanted to go back to sort of our revised IPSET thrombosis risk group. So again, how high or not are you for blood clotting if you have ET based upon your age, presence or absence of a JAK2 mutation, presence or absence of a history of a blood clot. And within those four groups, do we suggest antiplatelet therapy or aspirin in everybody? So it turns out in our very low-risk ET patients, they're probably actually not at too much higher risk for blood clotting than just the average population. So in my very low-risk ET patients, we don't typically suggest an aspirin unless someone is having bothersome microvascular symptoms. However, we do think there's data to support decreasing blood clotting risk in our low, intermediate, and high-risk patients by putting them on a baby aspirin, so we typically do suggest that. I wanted to point out a couple of caveats when it comes to aspirin use. So one of those caveats is something called acquired von Willebrand syndrome. So acquired von Willebrand syndrome is something that we can see in our patients with really high platelet counts, usually over 1 million. Von Willebrand protein is the protein that in all of us helps sort of with platelet clumping and clot formation. And when patients get this acquired von Willebrand disease, which we can test for with blood work, what happens is you get degradation of some of these von Willebrand proteins, and as a result of that, you're at higher risk for bleeding, especially when you're on aspirin in addition. So usually when we diagnose this in a patient, we temporarily hold the aspirin and we try to put them on a platelet reducing agent. We don't need to normalize the platelet count typically for this to go away. We just need to improve it a little bit and it'll resolve and you can put patients back on their aspirin. The other caveat about aspirin use that you might hear about is whether or not it's appropriate to use aspirin in patients with ET who have calreticulin mutations. And the reason is because there's some retrospective data that shows that aspirin doesn't actually decrease the risk of blood clotting, but increases the risk of bleeding in our ET patients who have calreticulin mutations. So you might not consider giving aspirin in an asymptomatic, lower risk patient without cardiovascular risk factors, and you might consider in your symptomatic, lower risk patients with cardiovascular risk factors, you may just want to put them on a platelet reducing agent and skip the aspirin altogether. Still a little bit of matter of debate though, but just wanted to bring up those two caveats. So when we talk about, well, what agents do we have to actually lower the platelet count, these are called cytoreductive treatments. And they're, again, agents to lower the platelet count. What are the ones that we use? So in the first line setting, one of the ones that you'll see us use a lot is hydroxyurea or hydrea. There are also certain instances in which you might find interferon being used in the first line setting. And in the second line setting, you'll see anagrelide being used, ruxolitinib, also known as Jakafi, being used, and then interferon is also used in the second line setting. And again, going back to that revised IPSET thrombosis risk score, so those 4 categories of risk, are we or aren't we typically sort of suggesting cytoreductive treatment? So in our very low risk patient population, we don't typically suggest that patients be on a platelet lowering agent. We only suggest it if someone is having symptoms related to the ET that isn't being well controlled with aspirin, for example. The same goes for our low risk patients, so low risk for blood clotting ET patients. And then in our intermediate risk patient population, we typically only suggest cytoreductive therapy in our symptomatic patients where we can't control symptoms with aspirin if they don't have any cardiovascular risk factors. But if you have an intermediate risk patient who has some cardiovascular risk factors, they smoke, they have diabetes, they have high blood pressure, you might consider recommending a platelet lowering agent. And we uniformly recommend a platelet lowering agent in our high risk for blood clotting patients. So these are patients over the age of 60 with a JAK2 mutation or patients who have had a history of blood clotting regardless of what their age. And again, there's no correlation between the degree of platelet count elevation or blood clotting. It's all these other factors. So once we recommend a platelet lowering agent in our patient, do we have a goal platelet that we want to decrease, our patient's platelet count to? So we have all these response criteria, right? There is this response criteria that groups have come up with. It's called the ELN-IWG-MRT response criteria. And as part of that response criteria, normalization of the blood count, so normalization of the platelet count is part of sort of how you would sort of meet criteria for a complete response, for example. There have actually been, though, several retrospective studies that have evaluated sort of the prognostic impact of actually achieving normalization of, for example, your platelet count in ET patients that were treated with a variety of different cytoreductive agents. And what did not seem to, and achieving those response criteria didn't seem to change the risk of bleeding or blood clotting or death from the disease. So really optimal platelet goal is not actually established, but I will say in kind of real life and day-to-day practice, more or less we try to normalize the platelet count if we have a reason to suggest that our patient be on a cytoreductive agent, specifically in that high risk for blood clotting patient population. But we don't try to sort of ramp up the dose at the sacrifice of side effects. So I wanted to really quickly just give a short blurb about each of these cytoreductive agents that we use, that we have in our armament right now to treat ET. Again, one of the most common ones, maybe some of you guys are on it, is Hydrea. It's an oral chemo pill. Is there data to support its use? There were actually a couple of trials that were published, one in 1995, another in 2005. The one that was published in the New England Journal of Medicine in 1995 took high-risk ET patients and randomized half of them to get Hydrea and half of them to not get anything at all. And what they found was that there was a statistically significant decrease in blood clotting events in the patients who were on Hydrea. The one that was published later in the New England Journal in 2005 was called the PT1 study. And what it did was it took high-risk ET patients and randomized half of them to be on Hydrea and aspirin and half of them to be on anagrelide and aspirin. And what they found was the patients who were on Hydrea and aspirin had fewer blood clotting and bleeding events. Now, I will say that about 20% of our ET patients will either become resistant to or intolerant of their Hydrea. Patients in particular who develop resistance seem to be at higher risk for disease transformation to myelofibrosis and acute leukemia down the road. What are some of the side effects that we do see with Hydrea? So we ask our patients about oral ulcers, which we can sometimes see, skin ulcers, fevers, anemia. There is a slightly higher risk for developing non-melanoma skin cancer. So I always like to have my patients go see dermatology for a nice once a year at least, head to toe good skin exam. And we do know that Hydrea is teratogenic, so you don't want to be using Hydrea in a woman who's trying to conceive or a woman who's pregnant. And then one of the things that I wanted to sort of just mention is that there has been a discussion about whether or not Hydrea is leukemiogenic. So does it actually increase a patient with ET's odds of progressing to or transforming to acute myeloid leukemia? And really, I think at the end of the day, there are lots of larger studies that show it is not, and so that it is safe to use and that we probably don't need to worry about Hydrea increasing our ET patients' risk of transforming to acute myeloid leukemia later. Anagrelide, what is it? It's an oral chemo pill as well. Is there data? There is. There was this study called the Anhydrate study that was published in 2013 where they took high-risk ET patients and they randomized patients to either Hydrea and or either anagrelide or Hydrea. It was what we call a non-inferiority study. So they weren't trying to prove that anagrelide was better than Hydrea. They were just trying to prove that it was at least as good as or not inferior to Hydrea. And they accomplished that. They saw that really patients had an equal kind of likelihood of having bleeding or clotting events. But anagrelide is associated with certain side effects. So dizziness, palpitations, diarrhea, fluid retention. And one of the things that was noticed in the PT1 study and other studies is that anagrelide does seem to increase risk of fibrosis or scarring. So I will say that for this reason, for the most part, we try to avoid anagrelide if at all possible. What are the other agents that we have for cytoreduction or reduction of the platelet count? So we have ruxolitinib. It's not actually approved in ET, but it is approved for the treatment of polycythemia vera and myelofibrosis. But there's data for its use in ET, that it can be useful in ET. So there is this study called the MAGIC ET study that was published in 2017. Were high-risk ET patients who were intolerant to or had developed resistance to Hydrea were randomized either to ruxolitinib or to best available care. And what they found was that there really wasn't any sort of significant difference in the proportion of patients who had normalization of their blood counts or who had bleeding or clotting events or even overall how the patients felt. But what they did notice was that the symptom response, the improvement in symptoms that patients had was faster in those patients who were on Jakafi, and sort of the decrease or the percentage of reduction in kind of how well or how poorly rather they were feeling was better in patients who were on Jakafi or ruxolitinib. And then there was another study published in 2022 called the RUXO-BEAT study. And this study took both treatment naive and previously treated high-risk ET patients, again randomized to either Jakafi or ruxolitinib or best available therapy. And again, there wasn't necessarily any significant difference between the two groups and who accomplished normalization of their blood counts, but Jakafi or ruxolitinib was better at shrinking spleens in those patients who had a big spleen, and was better in particular at controlling two symptoms that can be bothersome to our ET patients, so difficulty with concentration and headache. What are some of the side effects that we see with Jakafi or ruxolitinib? We look out for anemia, diarrhea, weight gain. There is an increased risk of opportunistic infection and viral reactivation. There is again an increased risk of non-melanomatous skin cancer. So again, all my patients on Jakafi or ruxolitinib, I like to have them get a head-to-toe skin exam by dermatology at least once a year. There's not a lot of safety data in pregnancy, so we tend to avoid it in female patients who are trying to get pregnant or are pregnant. And then finally, there are interferons. So interferon is the other sort of the fourth cytoreductive agent that you'll see us use in the management of our ET patients. What are interferons? It's a group of cytokines with immunomodulatory properties. And interferons were really the first kind of immune therapies that we had to use use in treatment of cancers, including in hematologic malignancies. The standard short-acting interferon alpha 2b was really difficult to tolerate. So there have since been development of these pegylated formulations of interferon, which have longer half-lives and thus need to be given much less frequently, and they're a lot better tolerated. There are three that you'll hear about. One is pegylated interferon alpha 2A, also known as Pegasus. This is a once-weekly subcutaneous injection. There's pegylated interferon alpha 2B, PEG-Intron, which is also a once-weekly subcutaneous injection. And then, more recently, there's RhoPEG interferon alpha 2B, also known as Besremi, not yet FDA approved in ET, but it's an every 2-week subcutaneous injection with the possibility of eventually going to just once monthly maintenance injections. With the pegylated formulations of interferon, we do still sometimes see side effects, and these things can include things like flu-like symptoms, lowering of the white blood cell count, autoimmune diseases developing like hypothyroidism, hepatitis, vasculitis, depression, and liver function test abnormalities. Interferons have been used and have been studied for the treatment of ET for decades now. And there's a lot of good data over the last over 30 years that have sort of revealed fairly notable responses. I wanted to highlight very quickly just a few of these studies. So one study is this MPN-RC112 study, and it was a phase 3 study of treatment-naive, high-risk ET, also PV patients. Half the patients got Hydrea, half of the patients got pegylated interferon alpha 2A, also known as Pegasus. And what you can see was that at the 12-month mark, it seemed that an equal proportion of patients were having normalization of their blood counts. But as our patients were treated longer, at 24 months and 36 months, more patients who were treated with PEG interferon had kind of greater responses in comparison to the patients who just got treated with Hydrea. The incidence of clotting was really very low in both arms and was not significantly different in either arm. It was 2%. I will say that more patients had side effects in the PEG interferon arm. There's one other sort of interesting thing that was observed in this trial, and that's in this sort of graph over here. So Dr. Nangalia mentioned this JAK2 or VAF, this variant allele frequency. So how much of this JAK2 mutation do you have in you? And what you can see is that initially, just like with the responses, patients who are both on Hydrea and PEG interferon had a reduction in the amount of JAK2 mutation that they had. But as patients were treated longer, patients who are on Hydrea ended up having a rise in their JAK2 kind of variant allele frequency, whereas patients who were treated on interferon had a consistent downtrend. Again, so there seems to be maybe a difference in sort of, it seems to indicate there's some sort of change taking place in, at the biologic level, and maybe we're seeing it to a greater extent over longer periods of time in the patients who are treated with interferon. There was another trial in newly diagnosed or frontline treatment-naive patients called the Dahlia trial. Basically showed, again, patients were randomized to either Hydrea or PEG interferon, and kind of an equal number of patients had a nice response. So interferon in these trials is not obviously superior in kind of controlling the blood counts and stuff, but it's at least not inferior. And then it's also been studied in second-line settings. So there was this MPN-RC 111 study that took patients with high-risk ET who had been refractory to or intolerant of Hydrea, and they treated everyone with Pegasus, and about 43% of patients had a response. Only 2% of patients had a major kind of vascular event. And even though 14% of patients on this trial ultimately withdrew because of side effects, more patients than not actually saw an improvement in their ET-related symptoms, which was nice to see. There was an interesting study that was published. It was a retrospective, a retrospective study at a single institution where they looked at all patients with MPNs who had been treated between the years of 2000 and 2020 with interferon for at least 3 months. And they looked at 381 patients, and of these 381, 169 had ET. And of those patients, about 78% of them had achieved a complete hematologic remission, meaning normalization of their blood counts. And at a median follow-up of about 72 months, it turns out 250 patients had discontinued their interferon, either for toxicity or maybe they had had normal-looking blood counts for a really long time and they came off. And at the time that they came off, about 67% of these patients still had beautiful normal blood counts. And what they saw was that 61 patients lost that control of their blood counts, and they had interferon reintroduced, and they were able to recapture that blood count control in 84% of patients. And the overall survival between the patients who had come on and off versus the patients who had just stayed on was not any different. So it's interesting, again, that with this one drug, with interferon, maybe you can kind of have these sort of treatment-free sort of periods, or one, I think the field wonders if, over time, if it does more to change the biology of the disease, can you maybe come off and never have to come on again? TBD. I wanted to make a mention of Besremi, which is Ropeg interferon alpha 2b. Again, it's not FDA approved in ET yet, but it is being studied. It's FDA approved for the treatment of polycythemia vera based on a couple of clinical trials. But like I said, it's actively being studied in ET. There's this one trial called the Surpass ET trial, which was a phase 3 randomized trial of high-risk ET patients who are resistant to or intolerant of Hydrea. Half of the patients got this Besremi, and half of the patients got anagrelide. And so far, this is what's publicly available so far, but what they saw was that more patients with ET on this trial who got treated with Ropeg interferon alpha 2b had clinical responses at 9 and 12 months in comparison to the patients who got treated with anagrelide. And you saw that so far what they've reported is that those patients who were treated with Besremi for this interferon had a greater reduction in their JAK2 VAF, or variant allele frequency. So more to come as they kind of present more data from this trial. I wanted to quickly mention 2 drugs that you may hear about or are hearing about that are actively being investigated in NPNs, including ET. So there's this one oral drug called bomedemstat. Bomedemstat is something that is an oral LSD1 inhibitor. What is LSD1? LSD1 stands for lysine-specific demethylase 1. It's basically an enzyme, and it's critical for sort of self-renewal of malignant hematopoietic cells and differentiation. So when you get loss of this LSD1 activity, you lose this sort of self-renewing property of your malignant hematopoietic stem cells. In mouse models of MPN, this agent has been shown to decrease counts, shrink a spleen, decrease inflammatory cytokines, decrease mutant allelic fractions, and increase overall survival. And the results of, it's been studied in patients now. The results of a phase 2 trial using bomedemstat in ET has been reported. And so this was a phase 2 trial in ET patients who had become resistant to or were intolerant of at least one standard of care treatment. And what they found was patients who were on this oral drug once daily for at least 6 months, 95% of them achieved normalization of their platelet count and did not have a new blood clotting event. And 83% of the patients who were able to stay on drug for at least 6 months maintained their platelet count past that for at least 3 months. What they also saw was that a vast majority of patients who had symptoms related to their ET who were on this trial had a nice reduction. 80% had some improvement, with the majority having quite a significant improvement in their overall symptom burden. We do see some side effects from bomedemstat. One of them is dysgeusia, or abnormality or changes in taste. Another that was reported included fatigue, thrombocytopenia, so the pendulum swung too wrong the other direction, meaning like too low a platelet count. Arthralgias were also reported, or kind of joint achiness, and diarrhea was also reported. Bomedemstat is actively in clinical trial right now. There's a phase 3 randomized trial in treatment-naive ET patients, where half the patients are going to get this oral drug and half the patients are going to get Hydrea, and we'll see who does better. It's a multinational, multi-center study. And then there's another phase 3 randomized study in patients with ET who are Hydrea resistant or intolerant. And again, half of the patients are going to get this drug and half of the patients are going to get best available therapy. It's also a multinational, multi-center trial actively accruing. So we'll see what the results of those trials are. And then finally, I wanted to touch on the calreticulin mutation and targeting this mutant calreticulin protein that gets produced as a result of this mutation in the calreticulin gene. So when this protein gets mutated, it kind of gets shuffled out to the outside of the cell, and it just sits there. And so it's a nice target, and it only sits on the outside of your malignant cell. And so it's especially considered to be a nice target because if you target it, you are hopeful that you're not going to target any of the normal cells. So a lot of clinical research activity, like Dr. Nangalia mentioned, thanks to her discovery of it to begin with. And so one of the trials that you guys might hear about is a trial by the drug company called Incyte, who has produced this monoclonal antibody called INCA033989, and it selectively targets the mutant calreticulin. So in mouse models, it seems to do its job by kind of decreasing platelet count, and it also seems to particularly kind of reduce the number of calreticulin mutated sort of precursor cells. So there are 2 phase 1 trials ongoing right now, one that's multi-center outside the US and one that's multi-center inside the US, and it is looking at calreticulin mutated ET and also MF patients who are needing a second or third or fourth line of therapy. Wake has the opportunity to be participating in this trial, and I have a couple of my own patients on the trial right now. And there are other sort of mechanisms by which calreticulin is also being targeted. There's a vaccine trial. There's another trial with a bispecific antibody that tries to kind of hook onto your calreticulin mutated myeloproliferative neoplasm cell and then put it and also hook onto your own immune system cell called a T cell and try to kind of make your own immune system destroy your MPN cell. So sort of action in ET and some hopefully exciting things to come. I wanted to just very briefly, last few slides, mention post-ET myelofibrosis. And the reason I mentioned this is part of why we see our ET, these are some of the things that we kind of look out for when we're sort of following our ET patients. So again, overall, likely never going to happen to most of our ET patients, less than 10% chance of transforming or progressing to myelofibrosis over an ET patient's lifetime. But, what are the things that I'm looking for in my patients that might start to make me think that my patient is one of those few patients who are going to progress to myelofibrosis? So what happens with myelofibrosis is your bone marrow starts to scar up. And so as that happens, as your red blood cells are trying to squeeze out of your marrow, they get these teardrop looks to them. So that's what this is. These are red blood cells, and as you can see, it's sort of this teardrop look to them. The other thing that can happen is your red blood cells, because there's not enough space in your bone marrow for all the cell maturation to happen properly, you can get these immature forms of red blood cells in circulation. So the red arrow points to nucleated red blood cells, which you're not supposed to see in circulation. And then finally, you can see less mature forms of white blood cells start to pop up in circulation, and this is a cell called a metamyelocyte. We're all supposed to have them, they're just not supposed to be in circulation. So those are some of the things that we're looking for that might give us a clue that our ET patient is starting to progress to myelofibrosis. These patients can also start to develop kind of fevers, unexpected weight loss, unexplained fevers. And so just wanted to point that out. In order to prove it at the end of the day, though, we need to do another bone marrow biopsy, and we use this thing called a reticulin stain to literally look at this scarring at the level of the bone marrow. 3 points. Young patients, so ET is the most common kind of MPN that we'll see in our kind of 15 to 39-year-old patients. They tend to be triple negative. They tend to clot much less. Our female patients are often of childbearing age, and so if they're using OCPs, we want to counsel them not to use estrogen containing contraception, because we think that'll increase their risk of blood clotting even more. We do know that ET patients can successfully give birth, but there is a slightly higher risk of first trimester miscarriages, preterm delivery, and small for gestational age infants. And we don't really know yet necessarily how to definitely decrease the risk of all those things. One of the other things that we often talk about is if our patient does get a blood clot, can we use one of the newer oral anticoagulants like Eliquis and Xarelto, and the likelihood is yes. And then finally, one of the things that comes up in clinic a lot is, I have a patient with ET, all of a sudden gets AFib, and cardiology puts them on Eliquis or Xarelto for stroke risk reduction, and then they come to me asking, what am I supposed to do with aspirin? And the likelihood is that in most of our patients, probably by putting them both on a DOAC and aspirin, we're probably just increasing the risk of bleeding. And so if they need to be on Xarelto or Eliquis for AFib, I usually stop their aspirin so I don't increase their risk of bleeding. So in conclusion, ET, it's a neoplasm, overall really good prognosis, but it does need to be followed and managed carefully to minimize complications like bleeding and clotting, and to look out for things like transformation or progression. We have some strategies to reduce the risk of bleeding and clotting, aspirin, hydrea, but we could use more. We have some agents that maybe change the biology of the disease like interferon, but really more investigation is needed, but there is some exciting investigation ongoing to see if we can accomplish, less thrombotic events, less bleeding events, less risk of progressing to MF or AML, and longer survival for our ET patients. That is it. Sorry, I went long.
All right, so I think we're going to have a panel at the end to include all the morning speakers. And since we're running a little bit behind, why don't we just take a 10-minute